Good afternoon. I'm Michelle Jones with the Alabama Department of Public Health, and I'd like to welcome you to this afternoon's program entitled Facing Fear, Crisis Communication and Disaster Behavioral Health. This afternoon we'll be talking about how effective communication with the public plays a role in how individuals and groups behave in emergencies. This presentation will discuss disaster mental health myths that can be expected in media coverage and which we should expel if we can. It will examine the ways that psychological responses to disasters influence our behavior. Principles of crisis communication will also be reviewed, and the areas in which communication can address psychological and behavioral responses will also be covered. This afternoon's program is produced by the South Central Center for Public Health Preparedness in partnership with the Alabama Department of Public Health. The South Central Center for Public Health Preparedness is a partnership of the state health departments in Alabama, Arkansas, Louisiana, and Mississippi, and the schools of public health at UAB, UAMS, and Tulane University with funding from the CDC. Before we get started with this afternoon's program, let me give you a couple of reminders. Registration, handouts, and the evaluation form can be found on our website. And you see it up on the screen, www.adph.org/ALPHTN. Throughout the program, we'll be putting up our 1-800 number and our email address for any questions and comments that you may have. We'll give you an opportunity at the end of today's program to call or email us at any time during the program for any questions and comments that you may have. Before we introduce today's speaker, let me cover the objectives that we are going to accomplish throughout this next 90 minutes. First, we'd like to be able to list basic assumptions about life that are violated by disasters, to be able to outline factors that influence people's assessment of risk and their level of fear, and finally, to be familiar with principles of crisis communication. And with us today, we have Mr. Penny Whiteside, who is the co-investigator and assistant professor with the South Central Center for Public Health Preparedness. And Penny, I'm going to let you introduce our faculty for today's program.
Thanks, Michelle. It's a real pleasure today to introduce our speaker, Dr. Ann Norwood. Dr. Norwood is Senior Advisor for Public Health Risk Communication at the Office of Public Health Emergency Preparedness in the Department of Health and Human Services. A graduate of Vassar College, Dr. Norwood obtained her medical degree from the Uniformed Services University, where she later served as a billeted faculty member for 15 years. Colonel Norwood transferred from her position as Associate Chair of Psychiatry at USU to join the Office of Public Health Emergency Preparedness at the Department of Health and Human Services as Senior Advisor for Public Health Risk Communications in April of 2003. She retired from the Army in May 2004 and continued in her position as a civilian. Dr. Norwood has written and spoken extensively on the psychological, behavioral, and social effects of trauma and violence, with a special focus on CBRNE and risk communication. She has co-edited 2 volumes for Cambridge University's press, Bioterrorism and Terrorism and Disaster. Dr. Norwood was also the co-editor of Trauma and Disaster, Responses and Management for Volume 22 of the American Psychiatric Press's Review of Psychiatry series. We're glad to have you with us today, Dr. Norwood.
Thank you very much, Penny and Michelle. First, a little bit how I got interested in this. I've worked in the area of disaster psychiatry for a number of years, and as a graduate of the Uniformed Services University, part of my medical school training was devoted to understanding the effects of nuclear, biological, and chemical agents, primarily on the battlefield. What I realized when thinking of terrorist events here was that a real potent shaper of behavior is the media and communicating with the public. And so then I became more interested in how do we talk with the public, especially at times of high anxiety and uncertainty. I'd first like to acknowledge colleagues. We have a long history of sharing slides with one another, so if any of them are watching and see something of their own, please note that I stole it from them. I'd like to first talk a little bit about disaster behavioral health. in some ways, it's a public health approach, really, to thinking about psychiatric and mental disorders and the lack thereof in the context of disasters. First of all, I will say disaster psychiatry just because it's easier for me, but it belongs to all of disaster mental and behavioral health. But for a psychiatrist or other mental health professional, it's really quite different than the approach we take in our daily work for most people. For one thing, rather than looking at pathology, we're focusing on ordinary responses to extraordinary events. Also, rather than thinking about individuals, we're looking at populations, just as public health does. What's the impact of a certain stressor, for example, on various populations and smaller populations, such as first responders, which I'll put a plug in for a friend of mine, Dr. Brian Flynn, who I believe is going to be presenting to you all on Monday, December 5th. And I would really encourage you to watch that, especially if you work with first responders. Also, in terms of disaster behavioral health, my primary focus is on the immediate aftermath of something bad. Actually, before that to preparedness, but then to the immediate aftermath, so that while we want to diminish morbidity and mortality associated with psychiatric and other disorders down the line, my immediate concern is how people will respond in a way that either helps the first responders get control of the situation, or in fact do the opposite, that is, engage in behaviors based on fear that either impede response efforts or put the person at higher risk for untoward events. So really I focus on behaviors. I hope people psychologically do well, but that really, to be very candid, isn't my primary concern right at the beginning, except as psychological issues affect behavior. Again, we want to emphasize prevention so that by doing the right things, both at response level and with our communications and outreach, that we can help prevent psychiatric disorders down the road. Again, you're not sitting in your office waiting for people to come and chat with you about how disasters are affecting them, but rather you think of innovative ways to be out with the public and offering them a chance to just ask questions or talk about their experiences. I think another way that mental health and behavioral health providers can be helpful to public health is by consultation efforts. I think for public health that you already have a great appreciation for the role of public information officers. But I think also that if you get experienced behavioral health providers that understand disaster and how that differs from your average practice, they can also be a very helpful tool in developing messages and so forth. And finally, like all areas of disaster response, really it's preparedness that you have to focus on. Now I'd like to talk a little bit about some of the challenges with crisis and emergency risk communication. Just as psychiatry and disaster psychiatry being a subset of psychiatry with differing focuses, so too with crisis and emergency risk communication. It grows out of the risk communication research, but then with a very special slant to it. For one thing, decisions have to be made very, very quickly in the midst of a disaster or a terrorist attack, and whatever one commits oneself to may be irreversible down the road. In other words, if you deploy resources to one city and then something happens at another, it may be difficult to change that. Also, with any of these things, outcomes are uncertain. For example, we all too well remember recent experiences with Hurricanes Katrina and Rita, and again, all the uncertainty that surrounded that, but it will be magnified if it's something we're not so familiar with. Also, one of the things that we've seen in numerous tabletop exercises over the years is that understandably, public officials want to get the facts before they go on camera or on the radio. They want to know what's going on to be able to convey that. Unfortunately, though, in our new era of communications, the news stories will be on immediately, probably from the scene showing live footage, so that really is a luxury that can't be afforded any longer, so that one of the roles of the public information officer and the behavioral people that are consulting is to make sure that the public official who is going to be on camera or on the mic gets out there right away, even just to acknowledge what has happened, what they know at the time, what they don't know, and what steps are going to be made to get that information. So really you have to focus and intervene on that natural tendency to want to have all the information. Now, the next slide is a graphic depiction of random numbers. The so-called chaotic equation is up at the top of the slide. And I post this as one I got from my former chair, Dr. Bob Orsano, at the Uniformed Services University, because I think it illustrates nicely that while one is in the chaos of responding to a public health emergency of some sort, there really is an underlying structure. And by being familiar with that and being able to predict what's going to happen next, even if it's predict that things will be uncertain, that helps both all of us in response areas, but also it helps us help the public by understanding their usual predictable things that are going to happen, although there will be some surprises along the way, unfortunately. Now, any disaster violates basic assumptions about life. In our country, maybe not everywhere, but there's a strong belief that the world is fair and just. Now, even within U.S. society, there are some segments that haven't had that experience, but by and large, that's something that many Americans believe. We also have a healthy denial of hazards and risk. For example, many of us have heard the statistics about how likely you are to be killed in a bathroom, yet most of us don't think of that on a daily basis. In fact, if we thought of all the things bad that could happen to us, we probably wouldn't get out of bed in the morning. So there's a certain amount of healthy denial of death, if you will, that helps us to go about our daily routine. Also, we like order. We like to know that certain things are running the way they should. And we like predictability, so that if I walk out my door in the morning, I know that the metro I need to take is going to be running at a certain time. I know what my schedule is for the day and so forth. Another very basic thing that's violated by disasters is one's sense of control. Suddenly things are very much outside of one's control, and I think we just, again, need to hearken back to our recent hurricane experiences to remember just how distressing that is for people. And finally, I think an area that both crisis communication and behavioral health have in common is to help people make some meaning out of something horrible. And I don't mean by this spin, but I mean by, if you will, looking at something about the common human experience and trying to help people think through various meanings to help them metabolize, if you will, the trauma and move forward. So again, these are kind of basic premises that we encounter every day, or that are outside our awareness usually, that are violated by a disaster or public health emergency. Now, there's a lot of mythology about how people respond to threat, and one of the problems with that is then sometimes public officials make plans to respond to these behaviors that are rare, which again is not very helpful at the time of a disaster. One of the basic, very human responses is for people to seek familiar people and places. This has been demonstrated very convincingly, for example, in in disasters involving oil rigs in the North Sea, where sometimes there are multinational crews on these oil rigs, and what has been witnessed is that when they have to abandon the oil rig and people are thrown in the water, for example, often many of these people will look to the rescue boats that have their particular nationality. So even if it means a longer swim, for example, if you're Norwegian and want to get to a Norwegian boat, you would probably die from that extra distance of swimming in cold water. So again, when something bad happens, most of us seek familiar people and places. Also, people tend to move away from danger and towards places perceived as familiar and safe. And again, I think if any of us look back at our own experiences, say for us in Washington, D.C. or New York or some place that was hit by a terrorist or natural disaster, there is this real strong drive, if you will, to be with your family and at home, that places that are familiar and safe. The other thing that I think is perhaps surprising, or maybe not to you, is that people typically fear separation from their family more stressful than the physical danger itself. So again, I think this is important for us in the public health community and other people planning responses to emergencies to keep in mind. One way that this, I think, is very important is often when we're planning for disasters and emergencies, we think of the thing that's most effective or efficient, but people don't necessarily behave that way. For example, one of the things that would on just a rational basis makes sense is in most cities now we have separate hospitals for children and for adults. So again, thinking efficiently, one would say send the kids that way and the adults the other way. But in fact, that would be, I think, really trying to swim upstream. The last thing you're going to do is get a mom and dad to let little Johnny or Susie go somewhere without them in the event of a disaster. So again, I think by understanding how people really behave and then making sure that what we're recommending is something that naturally they're going to want to do, or if it's not, then we need to also prepare them why they need to fight against this natural instinct to do X, Y, or Z. Now, there are a number of psychological responses that are common across disasters, terrorism, and emergencies: horror, fear, anger, paranoia. And one of the explanations for paranoia, I think, is this issue of control. We'd rather think that there's a band of people plotting against us than to realize that sometimes a single individual can wreak a lot of havoc. So there's a certain comfort, if you will, rather than saying sometimes we are quite helpless, to say, well, this ring of bad guys, wherever, did it. And so that also fuels things like scapegoating, and sadly, following lots of disasters, especially terrorism, there's often a tendency to look for people that are different from ourselves and then to stigmatize them. Other things that are talked about sometimes is the overwhelming outpouring of altruism, where people put other people ahead of themselves. Certainly sadness and grief are there. Also the uncertainty, especially with things like public health disease outbreaks, where you just don't know where will it go next, how quickly will our treatments work, and so forth. Also, there's terror when something really horrible happens, and I think this is vicarious sometimes for those of us who watched September 11th and all that. I think most of us felt a sense of terror. Another thing that we like to point to is that resilience really is the hallmark of how people behave. Overall, most people are quite distressed following a disaster or a terrorist event, but with time, virtually the majority, these symptoms will resolve. For example, they've done polls following 9/11 that showed virtually 90% of people couldn't sleep, were having difficulty concentrating, and so forth. But over time, those do fall off for most people. Now, there are groups that are more vulnerable, for example, those who were at the World Trade Center or the Pentagon, those who witness the events and have family members killed, and so forth. But again, the expectation is that most people will do okay over time unless we do something to interfere with that. Other things you can see is numbing and withdrawal, and those are, again, common responses. Now, why are psychological responses important? Well, in one major way, it's because they affect appraisal of danger. How much of a risk am I from, name the threat, from biological terrorism, improvised nuclear devices, and so forth. Another thing is that psychological responses, as I said, the tendency, for example, to scapegoat would be a maladaptive individual or group behavior, whereas adaptive ones would be that sense of community and drawing together to help, which again we would like to promote those positive adaptive behaviors and discourage the maladaptive ones. And again, this also goes along with people's behaviors. We tend to want people to use coping mechanisms other than smoking and alcohol and drugs, and to do things that get them more in touch with other people. Psychological responses, as I'll talk about, also affect physiological responses, and so therefore they're important. And finally, that if you're having an extreme psychological response, it can disrupt rational problem solving. And one of the goals of emergencies and public health communications is to encourage people to think rationally at a time of crisis. Now, I'm showing a slide, a quote from Franklin Delano Roosevelt that is very commonly quoted from his 1933 inaugural. And it goes, "Let me assert my firm belief that the only thing we have to fear is fear itself." And then the second part of this quote usually isn't cited, and that is, "Nameless, unreasoning, unjustified terror which paralyzes needed efforts to convert retreat into advance." So again, it's not fear itself that's the problem. It's when it becomes to a magnitude where it becomes terror which paralyzes people or has them operate in a way that is not, again, adaptive. Now, this is kind of my Goldilocks approach to fear. I think of it as a spectrum where in the middle we have appropriate levels of fear, which would be concern, a healthy dose of fear, so that you take self-protective measures, that you adhere to the recommendations of your public health officers and officials, and that you engage in what are called pro-social behaviors. In other words, things that help other people rather than, again, stigmatizing and scapegoating. Now, if there's too much fear, what one can see is panic, which leads to disorganization. Now, when I speak of panic, I'll have a couple slides dedicated to this. It is relatively rare, but one of the things that I think is important is that we as public officials, public health people, responders, and so forth, need to make sure that we're confident about our response capabilities and the safety of our families and friends so that we don't, quote, panic, close quote. Now, the other end of fear, which again is not particularly helpful, is too little fear, and that's what's sometimes called denial, where you just don't think about it, hope it goes away, or apathy. It's kind of like, well, I'll get my emergency supplies next week or next month. And this can lead to inaction, not taking credible preparation steps for whatever may come down the road. Again, if you go to the Homeland Security website, you'll see, or lots of other sites for that matter, you'll see basic kits that everyone should have on hand for, if you will, the disaster du jour. Now, in areas like Alabama that are, I guess, the leading state for sightings of tornado activity, wind funnels, then you would, again, probably be thinking that it's likely that you might be hit by or possible in any event, that you might be hit by a tornado, and therefore would want to take the actions to help there. For example, getting one of those emergency radios that lets you know immediately if there's a weather alert, making sure you have water and all those other things stored. The other flip side of that is bravado, and the example that comes to mind for me was following the anthrax outbreaks on Capitol Hill, where we didn't, very early on, didn't quite know the extent of where the spores were and where they were not, and there was kind of this table thumping saying, well, we're going back to work, we're not afraid. And that, I think, was not so prudent given the circumstances that they didn't know at that time whether or not their buildings had been subject to the spread of the anthrax spores. So again, bravado is not particularly helpful, nor is inaction. And at the other end, disorganization and panic is not helpful. So if you have just enough fear so that you're motivated to take self-protective and protective measures for the community, I think that's kind of where we like to have people and help them keep their fear in that range. Now, I think terrorism, sadly, is a way to really underscore some of the problems we have to face when talking about fear and uncertainty. One definition that I like is terrorism is an action undertaken to achieve a political, ideological, or theological goal through a threat or action that creates terror or horror. So many people will say that really terrorism is a psychological weapon, and therefore one needs to think about psychological countermeasures to that. And risk communication is a very potent way of doing that. The next, for those of you who are not viewing this, is a New Yorker cartoon that I love that shows two somewhat middle-aged or later ladies sitting on a park bench. And I like to say that I'm usually the one on the right, and depending on what venue I'm in, I pick on a colleague to be the one on the left. And it shows a series of fighter aircraft and so forth and bullets flying. And the caption reads, "Oh God, it's going to be one of those days." Well, I keep this on my door, and now I've changed it to one of those years, because we've just come from Katrina and Rita, and now our back to worrying about pandemic influenza. So again, that's sort of my attempt at humor about this kind of not so funny topic. Many of you are familiar with, I guess, the somewhat passé term of weapons of mass destruction, which refers to chemical, biological, radiological, nuclear, and explosive devices. And while they can be weapons of mass destruction, more often they're weapons of mass disruption, so that even if there's a perception of probability of getting ill or dying, they can really throw a wrench in how things work. And again, hearkening back to our anthrax experience, where sadly people did die, but in the end it was a handful of people, and we think of all the millions of dollars that went to cleaning up the areas and so forth, and which we needed to do, by the way. I'm not arguing against that, but that very contained, small, relatively small attack can exert enormous consequences. Now, what are some of the terror-producing aspects of CBRNE? Well, one is many of the agents are invisible and odorless, so therefore you can't tell whether or not you've been exposed, which again is a perfect condition for our active imaginations to go to town. Another thing is that these weapons often produce ubiquitous symptoms, frequently described as flu-like, which again, as we approach flu season, isn't particularly reassuring. They also produce what's called magical thinking, and again, that sort of talks about our fantasies of how things work, especially when we can't see them or feel them. And there's tremendous uncertainty on a number of levels, which I'll discuss in a moment. Also, novelty. Surprises are only fun, and even then not for everyone, if it's like a birthday party or an anniversary party or something like that. Generally, however, in the area of disasters and public health emergency, novelty is not good. Surprise is not good. And what we saw, for example, in World War I, even with very seasoned troops, that the first time machine guns were used, or the first time gas was used, that there was panic among seasoned troops. Now, I should also add here that some of that is not felt to be so much fear reaction, although to some degree it is, but also when you see your buddies running, you want to stay with your buddies. So it may be also motivated by that wish to stay with the familiar. But in any event, they did create panic, but over time the soldiers got used to even horrible environments of mustard gas, again in World War I, the trench warfare, dead bodies, and so forth. Other scary things about CBRNE is grotesqueness. If it produces, for example, one news producer, when we were talking about coverage of a potential smallpox outbreak, said, listen, all I have to do is show one picture of someone with smallpox, and I don't have to worry about sensationalizing anything. People are going to be terrified. It's a very disfiguring, scary-looking disease. So those kinds of issues also, understandably, ratchet up our fear and anxiety. Again, there is the potential for high numbers of casualties and dead, so that is sobering. Often, as we look at pandemic influenza, for example, there's a limited availability of effective treatments. And also with some of these newer agents, or some of them are old agents being used in a new format, there's uncertainty about the effectiveness of treatments. Sometimes it actually can be good news, for example, with anthrax, where we have newer interventions that created a better prognosis than historically was there. But again, there's always that anxiety, will it work? We think now about Tamiflu, for example. Is the organism going to develop resistance? If there's person-to-person spread, again, that really jacks up the sense of fear. For example, infectious diseases that are transmitted from person to person, such as smallpox or pandemic influenza in general, are scarier than ones where it's anthrax, where it's direct exposure to a spore, but not passed from person to person. Another frightening thing, especially about biological casualties, is that in the instance where they are contagious, because of our global travel these days, that very quickly biological people, patients, will be dispersed throughout the world. And again, as we talk, if you've heard in the discussions recently about potential pandemic influenza, this is of great concern. Also, another issue that comes up with relating to chemical, biological, radiological, or nuclear is that we don't have a lot of what's called scientific literacy in this country any longer, so that This is very specialized scientific knowledge that's poorly understood outside of limited professional groups and still a subject of controversy in the professional community. And one example where we're trying to learn from the past is, many of you may recall, especially those of you with a public health background, in the Midwest floods back in, gosh, I'm not sure what year it was, 83, 93, something like that. There was different advice given about how long to boil water from different levels of public health agencies, and that doesn't instill a lot of confidence in the public as a rule. So whenever possible, if we can gain consensus and agreement prior to something happening, we're in that much better stead if we're all saying the same thing. And I know those of you in the public health community are very sensitized to that and are working on consistent messaging throughout all levels of government. And finally, again, uncertainty is likely to characterize an incident because it's not visible and not we can't detect it with our senses. We don't know what the limit is of where it's occurred. And especially in the case of terrorism, I think, there's always the fear that there could be further attacks. So again, one of the things that we need to prepare ourselves for is that our messaging needs to really address the kind of questions our friends, we ourselves would ask following some event like this. Now, why is information important? Well, I think one of it is a quote I like from Sir Arthur Conan Doyle from The Hound of the Baskervilles: "That which is clearly known hath less terror than that which is but hinted at and guessed." And I think for anyone who's had a life-threatening illness where there's a gap between the test and the results of the test, know that there's, in a perverse kind of way, some relief once you finally know what you're dealing with, even if it's bad news, because it allows you to then focus on steps you can take to get better. So I think it's been pretty well debunked at this point that public officials should withhold bad news because the public can't take it. Usually it's quite the contrary, that the more candor, I'm not suggesting you put things in sensational news, and I think most of us from our own personal experiences know some people are better at breaking bad news than others in a kind, calm manner that is respectful of people's feelings and are just good at that. And I think in our own smaller communities, we should think of leaders like that and work with them to prepare for something untoward. Now, there are a number of disaster myths, and again, I think these are dangerous to be propagated, and the media usually just runs them again and again. Panic, as I'll have a couple slides to talk about in a moment. Looting, well, there was some looting in the hurricanes and in Andrew. It really is usually much less than is depicted on in the media. And one of the, I think, characteristics that you'll find again across most disasters is initially there's an overestimation of damage. Despite how awful it is, if we think back to the projection of deaths in the tens of thousands from Katrina/Rita, sadly it's gone over 1,000, but again it wasn't 10,000. So I think in the absence of information we tend to assume the worst and need to guard against that or just be aware of that. Price gouging, there is, for all of these, if you will, negative maladaptive behaviors, you will find instances of people doing them, but they're the exception, not the rule. Again, there's worried about contagion of deviant behaviors, and again, that tends to be overblown. The other one that really kind of is a pet peeve of mine is evacuation behavior is often described as panic, like there was panic at the World Trade Center and so forth. In fact, there's not usually. There's if we think back to the World Trade Center and evacuation of the very large, tall office buildings, there was very orderly evacuation behavior where people even stopped to help colleagues in carrying folks in wheelchairs down 80 flights of stairs or whatever that was. So again, that is unlikely. I mean, people are scared and move quickly, don't get me wrong, but they're not panicked. They're still problem solving, figuring out what's the best way to get out of harm's way and helping other people do it. So I think these are destructive myths that hopefully we can try to disabuse as we go along. Another New Yorker cartoon that I like shows sort of a picture in a typical boardroom, and depending on the most recent scandal, I'd choose the Enron boardroom or Martha Stewart's boardroom, and the caption is, "And while there's no reason yet to panic, I think it only prudent that we make preparations to panic." So I suggest that we not make preparations to panic, but rather to help people respond in a fashion that's appropriate and commensurate with the threat, and that helps everybody stay out of harm's way when possible. Now, just a few facts on mass panic. It's very rare, and if we think of some horrible events we've seen, such as the Tokyo sarin attack, the Scud attacks in Israel during the first Gulf War, the Oklahoma City bombing, Hiroshima, Nagasaki, and 9/11, there really wasn't mass panic. For the most part, I mean, you'll see a few people that perhaps personally felt panic, but the population at large did not respond that way. And the risk is provided by providing accurate knowledge, even if that is not good news. So again, I want to emphasize that you need to be candid with people. If things are not going well, you're upfront about it. You don't try to hide it. Again, you need to offer facts about how you're going to try to improve things, but not to be, again, worried that the public can't take it and that you're protecting them, because that is a very unhealthy dynamic over time. And another point that I want to emphasize for those of you in public health community, again addressing our own feelings of fear, is that training and realistic simulation very much decrease the risk of an organization experiencing panic and breakdown in roles. And for those of you, exercises are important, and when you exercise, I wouldn't so much be worried about a good grade, if you will, but by throwing wrenches into the work so that you really get a sense to feel like, oh my God, because there will be surprises no matter how well we prepare, and part of being prepared is understanding that there are going to be these surprises, things that we haven't expected that will happen, and we need to be able to respond and adjust our plans, not become unraveled if that does occur. Now, some of the factors that will increase the likelihood of panic is a belief that there's a small chance of escape from the agents. So this is kind of the fire in the theater effect, where people can have a stampede, which really is kind of what panic is. It's the human version of horses stampeding. If you see yourself at high risk, for example, if you're near the fire, if there are available but limited treatment resources. So again, I think it's very timely that we have dialogues with the public about pandemic influenza, what treatments there are, what resources, how we might allocate treatment priorities in the event of limitations and scarcity, and also the expectation that this may change over time as we learn more about variations in who the risk groups are with the particular strain of influenza and so forth. So again, predicting change over time, I think, is important too. It's not that people are necessarily stupid in the beginning, it's just that as they gain more information, like say a good football coach, they adjust their plan accordingly. And if there's a perception that there's no effective response, that the government is in disarray, again, that is not reassuring, and people may indeed panic then. And if authorities lose their credibility, and this again is why spin really doesn't have a role in any of this. And again, to preparedness, one of the things that isn't too commonly known is that Mayor Giuliani, I think, was universally regarded as having terrific skills in talking with the public following 9/11. Well, in 1993, following the World Trade Center attack, he assembled a group of experts in communication, and he developed a series of message maps anticipating things that would arise from a similar attack in the future. So he wasn't just making these up on the fly. He was very disciplined and very prepared, and had already thought about the different issues that would arise or might arise, and had worked on the best, most effective way of communicating that to the public and encouraging feedback. So again, I just want to underscore the importance of planning now for who's a good message giver for the various subpopulations. Often there are different cultural, ethnic groups. We have to think about communicating with those with disabilities. I've been gratified to see that in some of the hurricane coverage, the public officials had people signing right beside them. So those kinds of considerations, of course, linguistically, and different communities have different people they trust, and knowing that ahead of time is also helpful. Now I'd like to switch a bit to talk about the importance of perceptions. And there's a theorem from I.W. Thomas which is paraphrased: that which is believed to be real has real consequences. And this is something, again, where psychology and crisis communication have so much to inform one another, I think. Now, what are some of the factors that affect perception of how likely one is to have problems with the agent that's at hand? On the left side for those of you who have the slide in front of you, are the things that make it people less fearing that they are at risk, whereas on the right side, there are things that people feel would make them more at risk. So some of these factors are, if something is voluntary, for example, if we choose to smoke, then we're more comfortable with that kind of risk versus involuntary. So if someone, for example, locates a toxic dump near us, that is going to be less acceptable to us, and we're going to see ourselves at higher risk of adverse outcomes. Also, as we talked earlier about control, again, things that we control we're much more comfortable with than things that are controlled by others. And so that's one of the issues when we trot out statistics about motor vehicle accidents. While there is a substantial risk of being killed or injured in a motor vehicle crash, what is most reassuring to many of us is that if we're driving, we feel much better about being under control and having a chance to influence the outcome. Therefore, we don't perceive us personally as being at such high risk. Things that are familiar, this gets to the novelty idea. Things that are familiar are less scary than things that are new or exotic. Things that occur as acts of God, so to speak, are more comfortable than man-made events, such as problems with the breakdown of an industrial factory. Understandably, things that are reversible are less frightening than those that are permanent, so we see ourselves at lower risk. Also, statistical facts make us more comfortable versus anecdotal. If you know someone who said they were affected by, say, smoke from a coal factory, then that will be more powerful in influencing how we perceive ourselves at risk. Also, again, the idea of something that's endemic, that's there all the time, versus an epidemic, catastrophic events such as pandemic influenza. The familiar, the ones we're used to, are less frightening, and therefore we see ourselves at not such high risk. Finally, if the risk is fairly distributed, and so everyone's equal opportunity in terms of getting exposed to it, that's better tolerated than things that are unfairly distributed. So, for example, if often factories and other facilities that have a potential, if you will, of having catastrophes occur, frequently are located in low-income areas. So, again, that realistically does contribute to a perception that the risk may be unfairly distributed. And again, one of the things that is very common across disasters is that we're much more comfortable with things that affect adults rather than things that affect children. And some of the really poignant stories, I think, have to do with children. And it's something that even very experienced medical personnel, first responders, never really get over. It's just one of those things that has enormous impact on all of us. Now, there has been a fair amount of research that's been done over time, again in the context usually of some sort of hazardous mishap. And that is, for example, that perception and acceptance of risk are rooted in psychological, social, and cultural factors, and that our responses are influenced by family, friends, co-workers, and respected public officials, underscore respected. So if it's someone we don't much believe and don't think very highly of, that person probably isn't a very good spokesperson. Also, the mental strategies or heuristics that people use to make sense of hazards and risks have been studied. So again, those give us some guidance on how to develop messages. Now, this quote is by Paul Slovic, who's a very respected figure in risk communication. And it says, whereas technologically sophisticated analysts employ risk assessment to evaluate hazards, the majority of citizens rely on intuitive risk judgments, typically called risk perceptions. Hazards are scientific, objective, if you will, supposedly, threat assessments based on things like morbidity and mortality experiences. So by analyzing whatever the matter is of concern, they can, like on an actuarial basis, figure out what the actual hazard is. Now, the next slide shows how people's perceptions of what's most risky can differ quite widely, actually, from what experts would call. For example, there still is a very strong belief that nuclear power is very hazardous, when in fact, if you talk to most experts in the U.S., the way our plants are designed, our power facilities, is that they actually present a very low risk to people and threat. However, the League of Women Voters voted that their number one fear, whereas experts voted it number 20. Similarly, something where there's a discrepancy are X-rays. League of Women Voters had it pretty low down on their issue of level of concern. They gave it a 22, whereas experts give it a 7, because we know there is exposure to radiation every time one gets some sort of radiographic test. Now, the definition of crisis and emergency risk communication, one of the things I really want to recommend to you is that CDC and their partners have done a wonderful job on developing educational programs relating to crisis and emergency risk communication, as well as messages. So I really encourage you towards the end we'll have a slide listing some resources, but do visit the CDC website and look around and you'll find some very helpful sources for it. But the definition they give is that crisis and emergency risk communication is the effort by experts to provide information to allow an individual, a stakeholder, or an entire community to make the best possible decisions about their well-being within nearly impossible time constraints, and to help people ultimately accept the imperfect nature of choices during the crisis. And I think you'll see that, again, I hate to say common sense, because a lot of people don't think it's all that common, but that if you look at people who are good communicators, they'll explain the rationale for why they're doing what they're doing. And if it doesn't work out, they'll say, well, you know, we did our best job at it, and this is why it didn't work. This is how we're changing our plan. So again, I personally think that to the extent, again, not using jargon, but in a straightforward manner, you kind of walk people through why you make the decisions that you make. I think they'll be more forgiving in the end if those decisions turn out not to be so accurate or not as helpful as one had hoped. Now, CDC has 3 bullets they emphasize in their crisis and emergency communication, and those are to be first, again, addressing the tendency to wait till you have all that information before you go on camera or on the mic, to be right. So it's important that your message be accurate. So if you don't know it, don't say it until you have confirmation. And again, we think only back to the hurricanes to remember how a lot of the information was very, very wrong. I remember at one point, in any disaster, rumors are a problem, but there was a report that there were a couple thousand deceased bodies in the convention center in New Orleans, and that was thought to be so accurate, if you will, that we dispatched a DMORT team to recover these 2,000 bodies to find out indeed there were dead bodies there, but I think there were less than 20. So again, even when you have some people on scene telling you what's going on, it's very hard early on to get a sense of what the facts are. And this is complicated, especially if communications are impacted as they were with a hurricane. Now, what are some of the key principles of emergency risk communication? It really is a dialogue. You need to talk with people, and it needs to be a two-way process. One of the advantages we have in this day and age is that with all these quick and instant polls, we can get a quick sense, a read on, do people understand our messages? Are we answering the questions they want answered? And there, as you read the literature and the books and so forth that CDC has put out and other federal organizations and state organizations, you'll see that again there are different techniques for establishing a dialogue with a community that needs to be done, I emphasize again, ahead of time to make sure that these mechanisms are in place should disaster strike. Again, panic is rare, so stop wasting time trying to allay it. Emphasize in your messaging that there is a response process in place. And the next bullet says to avoid over-reassurance. And I would say just don't even use reassurance, period. I think the way people are reassured is by seeing that your actions are effective and make sense, and that reassurance is a byproduct of seeing that things are going as well as they can under difficult circumstances. Where there is uncertainty, you validate, acknowledge that, and again, as I would recommend, try to walk people through your decision making. Always, helplessness and a sense of anxiety can be really mitigated against if people have things to do, actions to take, whether it's self-protective actions or doing something to help others. The worst thing to do is when people are scared to just let them sit down and let their imaginations run wild with them. So channeling that effort and action first to doing self-protective and community protective actions, for example, thinking of perhaps elderly or disabled people who need a little extra help. Those things will go a long way to keeping the threat and risk in perspective rather than being overblown. Also, you express wishes for how you wish it hadn't happened or how you wish you could do this or that, but you just can't. The next slide shows a headline from the New York Times, which reads, "The truth hurts. Efforts to calm the nation's fears spin out of control." And this was in reference to the anthrax attacks. Again, not a time for spin, but a time for discussion and candor. Other principles of emergency risk communication, again, acknowledge the shared misery. We're all in this together when we face real obstacles. Provide anticipatory guidance. Again, going back to that structure of chaos slide, we usually know some of the different things that will be coming down the road. And to be able to predict those, just like for those of us who are doctors and nurses, being able to predict side effects, also when people experience those, build their trust in us that we know what we're talking about. So again, as you can predict that as we get more information, our recommendations to you may change, and then you can explain about vaccine production, when that will be available and so forth. That helps people have a sense of order being restored and helps diminish anxiety and fear. Some people, there's controversy about what-if questions, but I think it's often useful. Being a psychiatrist, we always talk about the question behind the question, and there are also often things that people won't articulate but kind of drive their questions. So I think, again, by talking to, if you will, your friends, average people in the metro or bus, to just kind of see what's on their mind and what their what-if questions are, that's very helpful for thinking about what fears are out there or what rumors and misinformation so that you can have a strategy to correct that. Again, you ask more people, and thinking of all the great leaders from Winston Churchill, FDR, so forth, you ask more people, you ask them to step up and help others, and you yourself need to be a role model. So if you're a director of public health and you're telling people that it's safe not to take antibiotics or not to stockpile them, and the next day industrious journalist reports that you in fact just went down to your local Rite Aid and got in a supply of Cipro or Tamiflu for your family and friends, that isn't going to go over well, and understandably not. Well, what can communication address? Again, remember, most people are going to act reasonably based on their understanding of the crisis. That paradoxically, some of the people that have the worst problem with disasters are those that are farther away from it, especially if they think that it's coming their way. So because they don't have any real experience, they're not seeing the destruction in front of them or seeing the hospital responding, their imaginations, if you will, get carried away, and so that they're more frightened than people actually confronting it. Also, as I mentioned, denial, that there isn't a problem, it can't happen here. Again, we're trying to see efforts to break through denial with respect to pandemic influenza. Avoiding stigmatization so that we don't go out as we have in several incidents. For example, if we think of the Atlanta bombing, where first this poor security guard was blamed for it, and then there's often, we want to hang whoever did it. We feel reassured if they're caught, but again, we need to avoid jumping to premature conclusion or closure about who did that. Again, helping to keep fear right in the middle of educated fear and concern rather than avoiding the fear. And we try to minimize helplessness and hopelessness and social withdrawal by giving people things to do and encouraging them to help out in their neighborhoods, families, and communities. Some harmful behavioral issues is that one sees sometimes that resources are allocated based on demand, whoever is the squeakiest wheel rather than an actual need. There are often, and sometimes justifiably, accusations of preferential treatment. There can be unreasonable trade and travel restrictions imposed. This was evident in an outbreak of pneumonic plague in India, where, again, people clamped down on travel from India when there was really not an indication to do so. You'll always see entrepreneurial individuals or charlatans trying to make a buck. And I think most of us can remember back to the anthrax, where you could go onto a website and order your Cipro from them. Or one of my favorites was in the World Trade Center aftermath. I heard a story about someone who developed personal parachutes. And my own mind was thinking, gosh, I was in Washington and we had a lot of vicarious or spontaneous, rather, evacuations, and I could only imagine if people had had parachutes in their hot little hands at those times, seeing people smashing down on K Street and Pennsylvania Avenue. So I hope that person doesn't sue me, but I have to say I do have some skepticism around that particular recommendation, where the cure may be worse than the disease. There are going to be doomsayers, and I recall again from anthrax that we were just in the midst of dealing with that, and already people were talking about smallpox coming down the road. So I think, taking maybe the disaster of the day and trying to say, well, yeah, there's other things are out there, but keeping that in perspective is helpful. And again, discouraging negative coping behaviors such as increased use of tobacco or drugs. Now, earlier I talked about the physical consequences of fear and anxiety, and the point is that there are a number of real physical manifestations of anxiety and fear. If you go back to the so-called fight or flight response, is that most of us, for example, in venues such as public speaking, have considerable somatic responses to anxiety and fear. For example, you can feel sick to your stomach or not hungry. You could have chest pain or chest tightness, sweating, diarrhea, dizziness, dry mouth, shortness of breath, faintness, flushing, rapid breathing, hyperventilation, lightheadedness, muscle tension, nausea, being pale, having heart palpitations, numbness and tingling in your extremities, shortness of breath, a rapid heartbeat, having to use the John frequently, and vomiting. And the important thing about this is, as you recall, I said that many of these agents produce ubiquitous symptoms. So what happens is when people start to experience these physical sensations, they often will attribute it to whatever the threat is out there that they're afraid they might have. So in situations where you fear you might have been exposed to gas, you would start to experience these symptoms and then proceed on the operational assumption that you may have been exposed and therefore seek treatment. This was a problem during the first Gulf War in Israel, where there was a real threat that chemical or biological warheads would be used on the Scud missiles that attacked Israel. And what they saw was, especially in the first attacks, before, as I say, people can get accustomed to very awful situations, but the first surprise kinds of things is that some people died because they didn't have the seal removed from their gas masks. And you can imagine if you're starting to feel suffocation, you might attribute that to actual exposure to gas rather than to the fact that there's something defective in your gas mask. So in that situation, you're in a lose-lose situation. And it's one of the reasons I think that we always have to think about the risk that countermeasures provide people or present people, rather than just saying, oh, they'll feel better if they have X, Y, or Z in their stockpile. Well, often there are downsides, for example, to antibiotic resistance and things like that. Now, speaking of these physical manifestations, this has been a real concern for especially hospital planners worried about surge on medical facilities. And one of the things that I think contributes to this is, again, the misattribution of the physiological arousal we experience when under threat, and people being rational, thinking, gosh, I'm going to err on the side of being cautious and have someone make sure I haven't been exposed to X, Y, or Z. And the surge can be increased by rumors and false information. So if we start to report without sufficient fact-finding that there have been simultaneous releases of whatever, and in fact there haven't been, again, that will certainly increase the numbers of people who feel they may have been exposed to something and then misattribute their symptoms, or accurately attribute their symptoms to the feared exposure. It's also, surge is contributed to because people are hypersuggestible. They experience following a severe trauma, or they're like easily hypnotizable and kind of will tend to do what people say, although not absolutely. And again, the importance of risk communication and rumor control in diminishing surge. Now, one caveat I have to say about surge is that, again, people tend to be cautious and prudent about their well-being, And we didn't see surge in Toronto during the SARS epidemic. Why? Because people realized that's where you caught it. So they avoided trying to go to the emergency room or hospitals because that was where the disease was being spread. So again, as we think, for example, of something like pandemic influenza, well, I'm not sure what to expect, quite frankly. And I think, again, that we need to be innovative of thinking of strategies to reserve and preserve our functions of our emergency departments, and to have alternate plans, which again we advertise widely before an event and then reinforce once an event happens. I want to give one example on the impact of a perceived threat. And this is an event that took place in Goiânia, Brazil, which is a large city in Brazil, in September of 1987. This is something that people often haven't heard of, but Goiânia is a city of about 1.2 million. And what happened was back in September of 87 is a couple of scavengers broke into an abandoned clinic where they had a machine there that was used for radiation therapy for cancer. And what they did was they wanted to use it for scrap metal, so they broke it apart in a junkyard, and then it was noted that some of the material glowed and was sort of phosphorescent, and people thought this was pretty cool stuff, especially kids. So it was distributed among those people in the junkyard and to some family members and to neighbors in that particular locale. And what happened was an astute person went to a physician a couple of weeks later and said, you know, I've been having such and such symptoms, and I wonder if it could be related to that funny powder we were passing around. And it was a very astute physician that put two and two together and alerted the authorities about this potential radiation contamination. As it turned out, in the end, it was 249 people had actually been contaminated, or 0.2% of the city. However, over 125,000 people out of a city of 1.2 million, so a substantial number of people, reported to a soccer stadium to be screened with Geiger counters, despite the fact that the radiation was contained to, I think it was a 6 or 8 block radius of the actual breaking up of the machine. And we'll go into some of the reasons why that happened. Only 50 out of the 125,000 required medical surveillance. 20 were hospitalized and 4 eventually died, one of which was a little girl who had contaminated hands and got it into her peanut butter sandwich, and so was exposed to a great deal of internal radiation. Well, as I said, in terms of the screening for contamination, between September and late April, 12.5% of the population had been checked at this stadium. This evaluation required taking time off from work or using weekend hours, traveling across the city, and then waiting in line for hours to be scanned. And over 8,000 people asked for an official certificate that they were not contaminated. Why? Well, because of the issues of stigma. And the other point I want to make was that approximately 11% of the first 13,000 who were waiting in line had what used to be called psychosomatic symptoms. In other words, they had real physiological responses to the stress of fearing they had been exposed. And this was manifest by nausea, reddened skin, diarrhea, and so forth, which are the classical symptoms of radiation poisoning. So you can see where the mind and the body are not, as Descartes would like to go along dualism, but rather are intimately connected, and so that we need to be mindful of this. The other thing is that after receiving a clean bill of health, their symptoms disappeared in a few hours. Now, again, I would caution against jumping the gun and telling people they haven't been exposed until you really know that that's the fact. And the next slide shows worried well with one of those European red slashes through it. This is a term that's often used, which I think is both misleading and disparaging and stigmatizing. Again, perhaps wrongly, I like to think of myself as pretty well put together and sort of like your average citizen. And if I experienced these symptoms and thought I might have been exposed, I would think I would like to be checked out. So again, I think by focusing on these are some people that are very different than us, we're missing the point that people given a threat and a perception that they may have been exposed, if it's less dangerous to go and be examined, will probably do so unless you give them a reasonable alternative. And by reasonable, I mean you need to make sure your facts are there before you jump to the gun and say they haven't been. Now, an example of stigma is a quote from the local press, and that is, the hearse carrying the first fatality, a 6-year-old girl, the little girl I just told you about who ate the peanut butter sandwich, who was to be buried along with her radioactive dolls to the Goiânia Cemetery, was blockaded and then stoned, forcing the driver to flee. Now, there was a lot of sensational press coverage of the event there, which stoked people's fears and played to scapegoating and stigmatizing. But there, again, a message for us all is that there are real consequences to that which is believed to be real. Economic consequences. The prices of agricultural and manufactured goods in Goiânia dropped 40 to 50% in the months that followed. All conventions were canceled or rescheduled as a result of stigma. Other very untoward consequences were that people could not stay in neighboring hotels. They wouldn't let them in. If you said you were from Goiânia, people didn't want to be anywhere near you, and they didn't want you coming into their area. And again, as we think forward to some of the issues that might be presented by a pandemic influenza outbreak, those are things, too, we need to think about, is how, well, thinking back to Katrina, where some people were not allowed to go into the neighboring communities by law enforcement. So I think, again, these are very real issues that we need to think about, or what, if you will, drastic measures might some people take, usually that aren't very helpful or short-sighted, to react in an inappropriate way to fear. Airplanes and buses refused to carry people from Goiânia, and people who traveled outside the region who were seen to have Goiânia license plates were stoned. And lest we be overly complacent and smug, I read you one other quote. It must be emphasized that this situation was not simply a case of, quote, ignorant peasants, close quote, flopping around in confusion. For example, doctors and dentists trained in the United States routinely refused to treat patients without those certificates I was telling you about. Unlike other emergencies, nurses refused to return from strike to treat contaminated individuals. So again, despite a lot of data that would show there's very low risk or threat, people reacted out of fear. And this, again, has been seen in numerous situations where the first folks out of pneumonic plague, I think it was Bombay, I may be giving the wrong city, but the first ones on the trains were private physicians. So, again, I think we can't be complacent or smug about this. Now, just to briefly go over the crisis communication life cycle, there's a pre-crisis stage, initial, maintenance, resolution, and evaluation. And to bang this table once more, do it in the planning phase, pre-crisis. That's where you need to establish relationships. That's where you need to discern who are the credible spokespersons in your various communities. And that's where you need to work with the public in thinking through some of the issues and to address communications towards them. So again, prepare during the pre-crisis phase, develop relationships with the media, other agencies, identify spokespeople and subject matter experts, give them media training, develop consensus recommendations, and test your messages. In the initial phases of a crisis, we want to acknowledge the event with empathy, and in simple terms, targeted about the 6th grade reading level, explain and inform the public about the risks. This is not the time to prove how smart you are by using big jargon words, but to try to be a plain communicator. Again, provide people with emergency actions that they can take, including how and where to get information. Establish your credibility and commit to providing regular updates. During the maintenance during crisis, you help the public more accurately assess the risk, provide background and detailed information for those who need it, gain understanding and support for the response and recovery plans, listen to feedback, and correct misinformation. You need to explain emergency recommendations, and when possible, frame the expectations again, talk about the predictable events, so that will reinforce trust in you, and support risk-benefit decision-making. Again, these are going to be decisions made under very strict time pressures and without benefit of a crystal ball. During the crisis resolution phase, you use education to improve the public's response to future events. You conduct an honest review of what worked and what did not work in the response and recovery efforts. You persuade the public to support public policy and allocate resources to the problem. And then in the evaluation phase, you evaluate your communication plan and its performance, and you document lessons learned and determine specific actions to improve your systems or the plan. Now, this next 10 tips are from the SAMHSA guide, which I'll show in a minute. And their first tip is to do no harm. And remember that words have consequences, so choose them carefully. And this is where, too, I think a behavioral health person can help you also think of nuances, at least those of us dinosaurs that trained back when psychodynamic issues and thinking of metaphors was popular. Number 2 is one I have problems with, and that's don't babble. Plan what you want to say, and I have a tendency to babble, so I wouldn't be a good communicator in crisis. If you don't know what you're talking about, stop talking. And this is particularly seductive, I think, for scientific experts to suddenly go outside their own area, or their own lane, if you will, once on camera. Again, focus on informing people rather than impressing them. Use everyday language or using metaphors, this is like kinds of situations. Never believe off the record. Don't say anything or write anything that you're not prepared to see in the news. And for those of us working on Katrina and Rita now as Congress subpoenas all of our email, I think this is a lesson that some of us are learning, unfortunately, the hard way. I have to share as a behavioral disaster person, I worry about the consequences of that, especially because leadership is so isolated during a disaster. And one of the way one tends to a healthy mechanism actually is humor in the right circles, obviously, so that I personally am somewhat troubled by taking things out of context and then hanging people by them. But that's my own Ann Norwood opinion, not HHS or anybody else's. Don't make promises you can't keep. Again, your heart will be saying, I would do anything to help you people, but ultimately down the road, things change and people aren't going to be so eager to give money. Don't use no comment. You always look like you have something to hide. Never get angry with a journalist because when you argue with them, you're just going to look bad. And don't speculate, guess, or assume. If you don't know something, just say you don't, and ideally tell the journalist that you'll be back to them and then follow through. So again, the summary of risk communication in a crisis is to be first, to be right, and be credible. And then just to recommend a couple of resources for you. Again, the CDC has a wonderful website, which is www.cdc.gov/communication/emergency/ and then you'll see some things to look at. Also, as I mentioned, SAMHSA has published a nice little handbook that you can order called Risk Communication Guidelines for Public Officials, and you can find that at www.mentalhealth1word.org/CMHS/emergency services/. And again, to summarize, be first, be right, be credible. Then my last slide shows a depiction that, of an ad campaign that people in New York City developed following the World Trade Center, and it shows 2 little boys with improvised capes and Superman outfits saying, even superheroes need to help sometimes. So I think by being creative, ideally ahead of time, we can really help our communities pull together and respond effectively in the event of a crisis.
Thank you, Ann. What I'd like to do now is open up our phone lines and give you a chance to ask Dr. Norwood any questions or relay any comments that you would like to on the information that she's just presented. While we're waiting on the phones to ring, Penny, I'll ask if you have any questions for Dr. Norwood.
Thanks, Michelle. I do have a couple of questions. Ann, you've talked a little bit about pandemic influenza, and since it seems to be on all of our minds at the moment, is there anywhere we can get some specific information about risk and crisis communication as it relates to pandemic flu?
Well, thanks, Penny. That's a wonderful point and question. There's a wonderful site that's just been stood up called www.pandemicflu.gov. And on that site, you'll see featured pretty prominently is communications. And if you go into that site, you'll find a really wonderful product developed by CDC and partners on crisis communication for leaders, by leaders, for example, which contains clips from Mayor Giuliani, from the aftermath of September 11th and anthrax, and also Governor Keating, who was the governor in Oklahoma at the time of the bombings there. So that's something that might provide nice entree to your leaders, and I think is kind of a fun way to hear from people who did the who did a good job on it. Other things are that will be posted shortly is there's been a lot of work done, again, pre any pandemic that might come our way, to develop a series of messages to both prepare the public ahead of time, and then also work is underway to also develop messages that could be used if a pandemic influenza should actually strike. So these are messages that have been piloted with different groups, have been tested. But again, I do caution that various communities throughout the U.S. differ a lot. So I would encourage local public health officials and their public information officers to find out what issues are of particular concern to their constituents, to their stakeholders, and then tailor the messages to your different populations within your community.
Penny, do you have any other questions?
Just one other thing,
Okay.
since we're talking about pandemic influenza, can you tell us a little bit more about some of the psychological or behavioral implications of pandemic flu?
Well, I think some of the psychological concerns I have, again, there will be a lot of uncertainty. Right now, if pandemic influenza were to strike, we don't have large quantities of effective vaccine, and there's questions about how much of a stockpile we have about antivirals, and indeed their effectiveness, since these viruses can change quickly and develop potential antiviral resistance. So we can predict that, again, there would be a lot of uncertainty and anxiety. Things that I think we need to guard against are, if you will, knee-jerk quarantine, where people, again, it's going to be very difficult, except at the very early stages potentially, to wrap our arms around and quarantine people, because there's a period of time, 24 to 48 hours, before you're symptomatic. So one can merely spread the virus before one even knows one has it. So in contrast to SARS, for example, where you could screen for an elevated temperature, that probably will not be particularly helpful in the case of pandemic influenza. However, I think there are isolated circumstances where quarantine may be needed and be helpful. But again, I think we need to guard against the appearance that we have to do something and doing something that's stupid. And indeed, I think runs a risk of, depending on how a quarantine is implemented, in the past in San Francisco during past outbreaks of contagious diseases, for example, the Chinese community was singled out for behavior. Other instances where, in a nice article by Judith Levitt, compares and contrasts the way smallpox was handled in Milwaukee versus in New York City, where the public officials basically went after immigrants and carted them off to sanitaria, whereas people who were, if you will, native Wisconsin people who didn't have accents and live in poor parts of town didn't have the same standards applied. That, in the sense of harshness, really provoked unrest and civil disobedience. So again, I think we have to make sure that we have a very measured and tempered response to whatever the real threat is, and not act out of wanting to look tough so people will feel reassured, because again, any action has potential for both good and bad consequences, and unanticipated consequences sometimes.
Okay, thank you. One thing that I found very interesting in a couple of slides that you did were the reactions that people have that we see so much on our 24-hour news coverage of the looting and the panic, and that is all we see. So it's nice to hear from you that is the exception and not the rule, because I think it is the tendency that all we see are a lot of those exceptions that are going on that gives us a different perception. So I think for me, as a public health person in our new role as responders, it's important to recognize that initially and to look for your credible public information officers and to get the right information out there, which underscores the importance of this training in risk communication for our information officers. So that was nice to see that was the exception and not the rule. We'll give you a few more minutes to call in, and if we don't have any calls, we'll go ahead and wrap up the show while we're waiting on phone calls. For those of you that do enjoy our preparedness series, Dr. Norwood mentioned one that's coming up Monday, December the 5th from noon to 1:30 Central Time, and it is on addressing disaster and emergency stress beyond first responders and implications for individuals, families, and the workplace. So I really encourage you to tune in for that broadcast because that one has implications for all of us. All of us can utilize that information. Another program that we have coming up is on Thursday, December 15th from noon to 1:30, and it's entitled Toxic Soup or Not, Hurricane Katrina Through the Lens of Environmental Health Preparedness. So we also encourage you to join us for that preparedness broadcast as well. We do have a call on the line. If you would, caller, go ahead with your question.
Hi, this is Dr. Len Singer, Cincinnati. There's a fair amount of controversy these days about critical incident stress debriefing for first responders. I'd like your comments on that.
Well, first, by way of a disclaimer, I've never actually taken formal CISD, CISM training. That being said, my concern is that any intervention that's effective can have side effects or negative consequences, if you will. And some of the issues and the controversy around debriefing in this particular model is that there is a direct concerted approach to pull up people's feelings. Now, if people are in high states of arousal, when I was mentioning the rapid heartbeat and so forth, there's a neurological mechanism where the brain is much more likely to be damaged in terms of traumatic images and so forth. So some of the concerns over time have been that, many actually, is that in heterogeneous groups where people haven't been given the same exposure to trauma, people can vicariously be traumatized and have these very intrusive images by hearing other people's stories. Another concern is that, again, historically, and I think that people who are proponents of CISD, CISM would say this was when the model was not used appropriately, that people have actually raced into positions and hampered the actual response by being in line of fire, for example, trying to debrief victims. So again, I would caveat that's probably people who are misusing the model. But again, I think the data there haven't been enough good studies to show the benefits sufficiently to outweigh the risks. What I do think is I grew up in, as you heard, in the military, and we use an SLA Marshall historical model, really, which is we have people who are in work groups together go through sort of an historical thinking of what had happened to them chronologically over time. And what you get is an opportunity to correct misperceptions. For example, in disaster, time is distorted. So what really took like 10 seconds may feel like it took 5 minutes. So if by having other people talk to one another saying, well, Fred, there was no way you could have gotten from point A to point B because there wasn't enough time, often that can alleviate people's sense of guilt and responsibility. One of the more compelling stories, examples of this I heard, was from Oklahoma City, where an ambulance had been directed to go to a certain spot and pick up people, and it was from a different part of the country, I guess. And at the 1-year anniversary, when they all got back together, it turns out there was a lot of festering anger at these particular people for not showing up where they wanted them to. And it was only when these guys said, well, we tried to get there, but some policeman pulled out his gun and pointed it at us and said, you're going where I tell you to go. So we diverted. So when you hear the whole context often, it helps you understand why people did what they did and doing the best they could at a very difficult time without benefit of a crystal ball. So I have, and again, in limited work groups, I believe that it helps people to talk about that, and if emotions come up during that context, I think one deals with them, but you don't probe in a way to pull those out, is my concern. And I have others, but that's sort of it in a nutshell, and that's a great question. Thank you, Dr. Singer.
Okay, we do have another caller for you. This next caller is from Minnesota. So if you would, caller, go ahead with your question, please.
Thank you very much. Appreciate it. We're calling from the Joint Information Center of Ramsey County, Minnesota. Just a quick question. Could you elaborate on worried well and what your concerns are about the use of such a term?
Again, I think it's sloppy thinking. It leads to sloppy thinking. I think it's much more helpful to think of what are the behaviors you're trying to encourage, what are the behaviors you're trying to discourage, rather than this sort of wastebasket term of worried well. Are we talking about people who are coming to the emergency room and refusing to leave even after they've been shown that all the tests are negative? Or are we talking to people who realistically may be at risk in coming? So again, I think it's more helpful rather than worried well, which I find just kind of demeaning and pejorative, to use the actual instances of behaviors we want to avoid and those that we want to encourage. And I think that leads to precision in planning and response.
Okay, thank you. I don't believe we have any other callers right now, so I would like to take this time to thank you for taking your time with us today to present this information to us. And Penny, thank you as well for joining us in the studio. I always appreciate it. Thanks to you, viewers, for taking your time with us this afternoon to learn about the importance of crisis communication and behavioral health. Again, join us for future preparedness broadcast, and as the show closes, there'll be some other broadcasts listed in the closing credits that we would love for you to join us again. And we will see you again next time on the Alabama Public Health Training Network. Thanks, and have a great afternoon.